children with disabilities were not being allowed to attend school and were not enrolled in school. So her action, she formed the Children's Defense Fund, which you guys have seen data from already today, and worked with several other groups to get the first IDEA passed and worked on the ADA legislation. This is wonderful for social justice in the United States. However, knowing that it was the children with disabilities and special health care needs that were in school, we never got any matching policy that said schools are going to be in some health care delivery business for us here. We never matched that. And so we have this kind of mismatch between a big, wonderful public policy and something, a big gap that was missing at this time in the 60s. Not yet corrected today, and I'm hoping this conference can be one of the impetus to start moving this forward. We have healthcare at the primary, secondary, and tertiary delivered in schools every day, and many of these healthcare services mirror exactly things that happen in hospitals and complex health systems. I was fortunate to spend the month of January in Japan. The Japanese government has enacted their equivalent of the ADA and IDEA just recently. So in 2009, it becomes operational in 2016. So I was there educating in several of their universities nurses to help them learn how to bridge this gap between this need for health care and wanting all children in school. So we have this system, and now I'm going to start directing this specifically to California. We really don't know what goes on in schools. We have no idea about the health care relief and the health care needs of children with special health care needs or what's happening to them. But every single time something comes up, there's a flu epidemic, a TB crisis, the asthma goes up, something happens, everybody starts rushing into the school, says, oh, help us, schools are the logical place to do this. Schools are where the children are. Wow, that's a really great idea. But who's at the school to help do that? The missing gap. Okay, so children come to school every single day. Any child in this photo could have a special health care need. Some may be obvious, some may not be obvious, but this limits planning. And it also creates safety concerns for us because we don't have any systematic way of doing this. So we do know that children are entitled to come to school. We also know anecdotally that sometimes they're told, we don't do diabetes here. I can't tell you the number of times I've heard that. Or it turns out you're going to have to take time off work to inject your child with the insulin that they need. And also the school personnel aren't trained, aren't monitored. So it's up to the parent. And we've just heard, who are these parents? Immigrant parents, parents with English as an additional language that are now trying to educate school personnel how to do healthcare services. So why should we be concerned about this? 57% of school districts in California report having no school nurse. Some of the ratios are as high as 1 to 13,000. That's what I call the why bother ratio. So who is doing case management, getting kids enrolled in insurance, ensuring that things are done correctly and safely for kids? They don't have to necessarily be the direct service provider, but they need to be the manager of health services at the school. They need to be the resource for the principal and the teacher. And for the parent, they need to help get the kids enrolled in school. And we don't know the answer to this. I'm still searching because everybody in this room, the only thing you know about is when there's a school nurse present or a school-based health clinic. And that's the minority of what we know about. Hey, so what can be done? Last year I was asked to do some legislative analysis on 2 bills for WOLC and PAN. And they both failed. They were both looking at getting more school nurses in school and more health services. And every single time it was this lack of data that was cited. So these recommendations are coming from the fact that we can't tell our story because we don't have the data to tell our story. I'm saying that we need to track and report emergency health events, 911s. Many states do this. That got passed by the legislature a lot. I would say, well, we're not sure if the kids are safe at school. And they'd say, well, tell us how you know that. Well, I just know because I know it. That didn't go fly. Not for another second. We need to be tracking attendance of these kids. We just described them as a risk group, but no one's monitoring them as a risk group. Yet we know graduation rates of children of color, of poverty. What about these kids with special health care needs? Substantial risk, and we don't track them. And then we need to make sure that all school health personnel have appropriate training, and was very appropriately brought up that there is standards for health care delivered in school, that there are techniques and things that everybody can rely on, from the teacher to the teacher's aide, that's supervised by school nurses. So remember, children with special health care needs, risk group. 2, we don't have any regulation or monitoring of school health services. Thank you.
I've been looking forward to this event for several months, and I was so delighted and excited to see this. It's right up my alley. So I would like to take the next 10 minutes to talk with you about some of the work that we're doing in terms of creating asthma-friendly schools to achieve equity. And it sounds like you guys, in terms of, you've really introduced the topic of asthma, and I'm going to echo so many of Diane's key points. And I want to declare that we were not in cahoots prior to this. So at the end of my presentation, I'm hoping that you will understand why asthma is important, and I think that you guys have already got that. What are some of the challenges faced in the school setting, and Diane hit on that, and you guys in the audience have hit on that as well. I'd like to talk about some of the strategies that actually work. What are some of the pitfalls to avoid, and hopefully, again, she did this as well. What are some take-home messages for you? At least 3 at the end of my presentation. So Diane, I was like, wow. We were channeling one another. So why asthma? What have you guys heard? I mean, 17%, you guys are really high. So the average, national average, is about 9 to 10% of children have asthma. So it's one of the most common chronic illnesses. It's also one of the most common reasons for missing school. Over 36,000 kids per day miss school because of their asthma. Children are 3 times with asthma are 3 times more likely to miss school than healthy children. As well, there is 1.7 times greater risk of experiencing an educational learning issue because of their asthma. So also, as you've heard, asthma is one of those health conditions that can lead to educational disparities. And it is a marker of health disparities as well. So what are challenges in the school setting? You guys have hit it, is right on. It's that staffing at school. So nationally, you guys are well below us. I think you might even be worse than Colorado, and we're one of the low ones as well. So 36% report having a school nurse. So this is horrible. We've also heard that the communication and coordination among school settings, the student and family, and the healthcare providers, they represent challenges. And a lot of this is because the school system and all of our systems are very complex, in that we lack unified approaches to how we manage issues in a variety of forms. So no one can keep up with the individual processes and forms, and everyone is lost. Therefore, the communication tools that we have created to support us are not working. So this is an issue, and what happens then, what it results in when we don't have this information, is that kids do not have quick access to their medications. The school personnel who are trying to support them do not understand what the individual needs are of that student and how to manage and support them during worsening asthma. So this really prevents them from being full participants in their school experience. So what do we know that works? Yes, if we increase staffing at school, we get improved outcomes. So staffing at school can be bringing in a full-time nurse, it can be providing a physician consultant, school-based health clinics, or even what was done in California, you guys know, in terms of bringing in an asthma mobile clinic. So all of these have worked, and one of the biggest things that they work is, and you've heard this, it's ridiculous really, but we call people, family members, to come and remove them from school so that they can administer medications. It just blows my mind. I also was in Canada, and it's the same thing that happens. So we are pulling kids from school, pulling parents out from work, other family members. They're scrambling around to cover to bring in medication. So of course, what does this lead to? It actually leads to reduction in 911 calls, improved student attendance, emergency department visits, and improved school absenteeism. And it has been shown to be cost effective. So also in terms of when we bring in more support, we can expand the services. And typically the expanded services that we do are case management and care coordination. And these have been primarily for those who are most at risk or they have poorly controlled asthma. The other thing that you've heard talked about is they provide directly observed therapy for maintenance medications. So maintenance medications are really not when the child has symptoms, but they're really to keep that asthma under control and are taken on a regular basis. So this leads to improved medication adherence, improvements in school absenteeism, reduction in exacerbation rates, reduction in urgent and emergent care services use. The issue with this one is when you do this level of care, it is extremely resource intensive in terms of bringing in human resources and the cost associated with that. The other thing that's extremely important is that asthma is a chronic illness and it is complex because it's changing all the time. And the person's asthma changes for them and it varies according to individuals. So really they need to have a set of core skills so that they can be successful in managing their asthma, not only in a school setting, but also to be successful in managing their asthma as an adult. So what we've done is we've actually taken proven, effective curriculums for self-management. They're provided in the schools. The other that's even been shown to be beneficial is often there are some kids that you see they are using their inhalers daily. So those are what we're calling, and there's those teachable moments. So when you see the student, you're really providing teaching opportunities. Others have given them and used electronic information or information technology in terms of the internet, CDs, DVDs. And again, we have shown that this improves asthma knowledge, their confidence, their skills in terms of accurate use of an inhaler. So many times we're not teaching inhaler use. If you don't get the medication in, it's not going to work. This has improved school absenteeism, reduced the need for urgent care, emergent care, hospitalizations, and has also improved academic performance. So this is something I did say that also asthma is one of those ones that leads to educational disparities. So the other important area, it kind of fills into a cluster, and it's really enhancing the infrastructure of the school setting, and that is creating asthma-friendly and supportive environments. And this is important because often the reason that our efforts fail is because we haven't looked at the system in which individuals need to work. So interventions have focused on asthma-specific policies and protocols and developing and using supports to help them implement those policies, such as identifying which students have asthma. Which are the students that we need to focus on who are going to need more care? They're more at risk for experiencing considerable morbidity. Developing standardized protocols for managing worsening asthma. IT support or information technology support is key. So this is the academic platform that they all use. This is a way of communicating, at least amongst the school setting. And we have seen improved outcomes with these activities as well. So what are the lessons learned from this is that I find that I've had to walk in both worlds and have finally become more knowledgeable in the school setting. But typically we go in as healthcare providers who work in traditional healthcare settings. And we do not understand the complexity of an educational system. And we think that it should run like an educational system. And we have no idea that actually it can be more complex and more difficult to navigate than the healthcare system. So really we have to look at bridging these systems. Schools cannot fix the pitfalls and the issues with the healthcare setting without traditional healthcare setting, without support, financial as well as human resource capacity. School-centered models and approaches do make a difference to improving the lives of children with asthma. They can reduce educational and health disparities, but they require a complex, multifaceted approach. So the issue here is really trying to find that sweet spot. We know what's working, but it is very complex and can still be costly. We have not figured out exactly the sweet spot. Where we're heading to now is also working through a policy landscape because we think that that will help us in terms of if we legislate things that they happen. Again, that's another talk. But in 2004, all 50 states had legislation that allowed students to carry and have easy access to their inhalers and anaphylaxis medications or epinephrine. What currently is at the House is a proposed bill for asthma management plans in school. What is interesting is that this will allow schools it will actually pay for schools to stock medications, asthma medications, and anaphylaxis medication. It requires a school nurse on site who's trained specifically for asthma, and they must implement a school management plan. This management plan is actually based on the best available evidence. So they're mandating that you must have a process in place to identify a child with asthma, a student with asthma. You must have an individualized plan. They must have easy access to their medication. You must have school personnel training, that it goes over the school policy for in general, an approach to manage worsening asthma at school. That you have to have a system in place to support coordination among the student, the family, the healthcare provider, and the school system. And, to what Diane is saying as well, which we're all needing, we're working on this in Colorado, a method to monitor the quality and outcome. Because typically we have no clue. So, in terms of what's going on, I just wanted to say north of the border is that within the last 6 weeks, they've actually passed legislation to hit this. Take-home messages. Successful school asthma care requires a dynamic, multifaceted, tiered approach to meet the changing needs of students with asthma. Infrastructure and supports are necessary, particularly standardized and unified forms. In Colorado, we're working on this so that there's a standardized form across the state for identifying students with asthma, identifying where they are in terms of the needs, the higher risk students, and also a combined medication administration, FERPA, HIPAA form that goes over exactly how to handle or support this student in successfully managing their asthma. And the bottom one is finding funding models for sustainability is crucial. And hopefully I've expressed to you that really in terms of successful asthma management and helping supporting these students becoming successful at school and into their adult life requires a village. Thank you.
It's nice to see you all here. I was just sharing with my colleague Linda Lenoir, who's our district nurse in Palo Alto Unified. Palo Alto is the city that is adjacent to Stanford University, and we were speaking about, she whispered in my ear for the last talk, she said, this might not be something that you're as interested in. And then we started talking about how we were whispering, actually. Mental health, actually, you know this, it's a very high comorbidity with children with chronic asthma. And where I trained in the Bronx, we didn't call it asthma. Anyone here from the Bronx or from New York City? Anybody? We called it asthma. Asthma, that's right. So we had a lot of, when I was a pediatrics resident, we had a lot of kids who had this kind of imperfect storm of family stressors, poverty, acculturation stress, and chronic asthma or other conditions related to respiratory badness, we used to call it. So I actually think it's kind of nice that I was put right after you to speak about this, because mental health comorbidity, particularly with asthma and chronic respiratory conditions like cystic fibrosis, comorbidity is actually quite high. So 40 or 50% or more, depending on the community. So I was asked, so I know I probably just took up a minute of my 10 minutes. I'm going to speak about some of the lessons learned from our community, but also what's going on nationally with regard to prevention and responding to depression in the school setting. Prevention meaning of worsening depression, and depression leading to desperation and suicidal thinking. What would you say is the highest risk for teenagers with regard to suicide and getting caught up in a suicide cluster? In any community, what would you say is the highest risk, or what are the risk factors that come to mind for you? Somebody else committing suicide. Spoken like someone in the field. Yes?
Questioning sexual identity.
Okay, sexual identity in general, sexual development, whether it's your own identity, who you're attracted to, and how that is experienced in the community, absolutely, or in the family. What else? So we do also think about prevalence of depression and other mental health conditions, because in the vast majority of young adults and adults, 80–90% of these folks have a diagnosed mental illness or mental health condition. And in teenagers, most of them also have a mental health condition, but it often goes undiagnosed. And Lisa Chamberlain talked about it a little this morning, and talking about the Ravenswood experience. A lot of these kids may be identified in primary care, but then they may not get services. Many of them go under-identified. But schools, the reason you're all here, and the reason I was asked to speak about this is, actually, we've known for some time, and Kimberly Hoagwood, who was at the MMH for many years, who's now at NYU, has written a series of papers and done a number of studies on this, looking at schools really continuing to be the primary providers of health services, particularly mental health services for children. And it would be really nice if we had designed this. But actually it ends up being by default, lots of nodding heads. Because those of you who are on the front line in school know that you're either meeting with these kids yourselves, or you're calling the psychiatrist or psychologist or therapist in the community. So it would be better if we could design some things that are known to work. We also know that among the kids who actually do receive these services, 75%, we're having a little trouble with the slides here, are getting their services in school. So it's a matter for a lot of these kids of being able to connect with someone in school, and they may identify with a counselor, a teacher, another trusted adult to whom they're going for support. And what I think we might do is, why don't we try to exit the show so that we can just play it from slideshow instead of from trying to match it with the, I guess this one's okay. All right. Okay, yeah, I think it's all right, yeah. And there's just maybe glitchy with the other slide. So we think about depression. When we think about kids who we identify in school who may have depression, we're thinking about teenagers around sophomore year. And we know that teens and children can present with depression. What would you say about prevalence in terms of male versus female as children? Is it about the same, boys and girls? About the same. What about as teenagers? Well, boys, when they get depression, it can be more severe. Girls actually have a higher prevalence, and it's about 2 to 1 more in girls. And you might think about, biological, endocrinological, and social developmental reasons why girls might outdo boys there. Girls tend to develop earlier and are socially a little more conscious and a little more advanced and a little more affected, perhaps, by relational issues. But over time, what we see is when there is severity of depression, boys can go underdetected because they're not really socialized to talk about their feelings. By the time they graduate, how many have had an episode of depression, of major depression? 10 to 15%. But if we think about depression of any kind, where they have been so sad for two or more weeks and they've had a loss of interest, then that's up to a quarter. When we give these presentations in classrooms, the kids really sit up in their seats because teenagers know that they all know someone, either in their family or in their friendship circle or themselves, who have been affected by major depression. And we, of course, know in this field that the apple won't fall far from the tree, and so up to 50% of teens will have had a relative, particularly a parent or some first-degree relative, with depression. When we think about pathways, I keep using this slide from my colleague Francis Wren. Again, just the wrong combination of genetics, life experience, and brain issues that interact with the environment as a whole. And while we know that mental illness far and away is the highest risk factor, environmental factors are really important, and they're taking on even more in terms of research interest for us to understand what these factors are. Interpersonal stressors, social stressors, cultural stressors, that can affect a teenager's typical development. So normally, we would expect teenagers. How many of you are raising teenagers now, or have raised teenagers? So you'll know what I mean. How many of you once were teenagers? So think back to what it was like when you were. It's a lot different now, right? So much of what we hear about on social media, the myth of social media actually is that teens react very strongly. So they may reach out on social media for support, but they may get very upset. They may lose their ability to bounce back. They may not really be able to have a capacity for humor. That's when we might worry that something else is going on. Their anxiety, that again is part of a normal, everyday adolescent life, if they're not able to bounce back from that fear and that worry, if it's affecting their sleep, if they lose their ability to stay positive, if they get easily discouraged, if they go from being a person where the glass is half empty, half full to being half empty, we start to worry that something else might be going on. The problem, of course, in school settings is that school staff may be unsure of their roles. What do I do? Do I engage with them? Do I call the parent? Peers themselves may not be able to recognize signs and symptoms of depression, and kids themselves may not have the language, particularly younger kids, to talk about what it is that's affecting them. So we call these a number of barriers to help seeking. So in Palo Alto, you may know that we've had a number of interventions in our community to help educate the community, and particularly the teens, to look for signs of depression, and when depression turns to desperation, and when kids consider taking their lives. Because we've had 2 suicide clusters now in the last 6 years. This is an exceptional community to live in. My wife is a nurse, by the way, nurse practitioner. We're raising 3 boys, and we've seen a lot in our time here. And most recently this year, 3 of the teens who died were Asian American, and that's generated a lot of interest around the diverse nature of what happens in a suicide cluster, and when kids are getting help for one another when they think, well, my friend might be in trouble. We know there are a number of positive factors. I want to highlight a couple because I'm running short on time. Focusing on positive school connections. Someone mentioned school climate earlier. That's one of the most robust indicators of help seeking. If school climate is a place that encourages kids to seek help, not only for themselves, for one another, if they know how to get help, and if they have a number of peer connections, not only with kids in their own friend group, but they feel like they might be able to go to a friend's friend. Particularly the perceived availability of trusted adults, a very robust research finding. Not only who is available, but it's the perception of who is available, not only in the community, but especially at school. And this idea of social support and connectedness is something that gets measured. We've had a coalition called Project SafetyNet, and there were 3 major areas of intervention: education, prevention, intervention. And what we try to focus on in our group is when we go to schools, we really focus on the teens and depression education. With parents and with teachers, we talk about suicide prevention, looking at signs, looking at what you can do as a parent and as a trusted adult. I see that my time is up. I'm going to just end with this slide, which is called the Supporting Alliance. It was actually developed by someone here at the School of Education at Stanford, and it's the idea that we do actually a pretty good job with parents and teachers. Those of you who are raising kids, you remember how warmly you were welcomed that first day of kindergarten, right? The teacher opens the door, she's giving you a hug, or he wants you to stay after so that, you can sign up for volunteer opportunities, right? And as we get older, we find out as our kids become teenagers, we become more and more suspect if we come on campus, right? Why is that parent on the quad? Why is that parent coming to the office? Something must be going on with the student. So we like to actually propose the idea that we're all trusted adults trying to take care of the student here in the middle. So we know that parents and doctors work with one another, but what we need to do, and what we try to do in our training program, is enhance this alliance between the doctors and the therapists and the teachers and the school staff. And we call this the Supporting Alliance. That term was coined by Noah Feinstein, who's now at the University of Wisconsin. He wanted to know how these groups of adults work together, particularly for kids with autism and other chronic mental health conditions. In our group, we're interested in understanding about peers, and how do peers really help support one another, especially when a friend is in distress. Not by turning them into junior psychologists, but actually by connecting them to a trusted adult on campus. And so this is a focus of what we do, and the role of collaboration is simply the idea that teachers are asked more and more now with mainstreaming and push-in programs to deal with classroom heterogeneity. And if we can improve what's called their instructional tolerance, we can mediate teacher stress and burnout. We can prevent teacher stress and burnout if we have good collaboration. If we don't have good collaboration, we actually can see that there were a number of teachers who we lose who are excellent because there are all of these other pressures that they have. Last slide talks about what are the three take-home points are the policies now that are being looked at. Tim Ryan of Ohio and Susan Davis of California have introduced legislation. Some of you know this, the Academic, Social, and Emotional Learning Act of 2015. This is where finally the feds, now this is the third go-around, they're trying to link the academic outcomes with the behavioral and the emotional outcomes, realizing that they're inextricably linked, right? Happier kids who are resilient are more likely to be engaged in their schoolwork, and vice versa. In California, we have a student mental health policy work group of Tom Torlitson, who's our state superintendent, and similar to what's being proposed in the Social Emotional Learning Act, this requires newly minted teachers and administrators to get basic training for mental health in the classroom. What might a student in distress look like in your classroom? And finally, in our district, Palo Alto Unified, largely through Linda's advocacy and others, we have a board policy and administrative regs that allow us to conduct suicide prevention and wellness promotion as part of the job that the school does. If school's job is to make sure, and the school nurse's job is to make sure the kids are healthy enough to learn, then mental health is part of health. And passing the board policy then allows you to be able to conduct best practice and actually use instructional time to be able to teach about stress, wellness, resilience, depression prevention, etc. So I'll stop there and then we'll take more questions on the panel. Thank you.
Thank you. I don't know if it's a good thing to be the last person before break, but here we go. So today I'm going to give just a few of the findings that came out of our 6-year demonstration project. Our project was funded by the Seal Packard Children's Hospital and the Seal Packard Foundation for Children's Health. So what we did was we put a full-time school nurse at 4 schools in San Jose Unified. All of our schools were low socioeconomic, highly Hispanic. That's how they were chosen. So we looked at if we put a full-time school nurse at schools and we created this collaboration and linkage with our local school health clinic, the nurse practitioner there, we felt that we would improve the health of our students and their families. One of the key points that we did, though, that extra bubble there, is we have a grant evaluator, and it was Dr. Rodriguez here from Stanford. And Dr. Rodriguez helped us develop our planning, our logic models, our objectives, and we met regularly, and she kept us on task. When we would have questions like, gee, I wonder if our students with asthma are achieving at the same rate as our students without asthma, Dr. Rodriguez would look at the data and figure that out for us. So it was a continuous improvement, ongoing cycle throughout the full 6 years of the project. So a snapshot of San Jose Unified. We're the largest school district down in Santa Clara County. I think you and I grew up on the same street. We have 32,000 kids, pre-K through K. We've identified 25% of our kids that have chronic health problems, at least one. Now, a bunch of these kids have more than one chronic health problem. And then there's lists of some of the major, more interesting chronic health problems that we have. But if you look, we have 3,200 kids identified as having asthma. So we tended to focus on asthma for this project. This is Janice Asadi. Janice was one of our program school nurses, and she was at Empire Gardens Elementary School. And in here, Janice is giving a vision test to one of her students at Empire Gardens. So we asked ourselves, what happens when we put a nurse like Janice in 4 schools? And all of our schools, like I said, were low socioeconomic, 82% free and reduced lunch, 82% Hispanic. And this is kind of what we found. We found improved access to healthcare. And one of the ways that we measured improved access to healthcare was we looked at the kids who had, say, vision referrals. School nurses routinely screen kids for vision. We do it in California, we have mandated grades. We do it in kindergarten, 2nd, 5th, and 8th grade. And when we find a potential vision deficit, we go to the parents and say, hey, we'd love you to take your child to the eye doctor because we think there's a vision problem. But even though we offer free glasses through Lions Club or free glasses through the VSB voucher program through NASN, the families don't take their children to the eye doctor. So over the course of the 6 years, if we had a part-time nurse, they averaged 52% of those vision referrals, those kids who were referred were actually seen by a healthcare provider. In our full-time nurse, 91% of the kids identified with a potential vision deficit were evaluated by a vision specialist. The same ratio held true for our hearing screenings. We also looked at asthma management. This is Claudia Park. She's another one of our nurses. She's at Andarm Elementary School, and she's checking the lungs of a student. 100% of our kids with asthma were monitored by the school nurse. Now, it may be that as simple as every year the nurse would check with the parent for signs of asthma. Is your child sleeping well? Noticing the extra cough? They just do a quick assessment for the parent. And it ranged all the way over to where we were doing case management of kids with asthma. So we were, for example, teaching the child how to use his inhaler, working with the healthcare provider. And one of my favorite stories out of this project came from about a student who had asthma. And the nurse noticed the child was coming into the health office frequently using his rescue inhaler. So she went back and forth with the parent, and the parent was saying, oh yeah, we're going to the doctor, we're taking care of it, and yet he continued to come into the health office for his inhaler. Finally, after several encounters with the parent talked to the nurse and confided. She said, you know, my husband and I, we only speak Spanish. But our doctor, who was assigned to them, the Medi-Cal doctor assigned to them, he speaks Chinese and we don't understand what he's saying. So within the month, the nurse had the family reassigned to a new physician. The family chose the nurse practitioner at our school health clinic. The nurse practitioner and our school nurse communicated. The nurse practitioner adjusted the asthma regimen, and in a very short amount of time, that child was no longer in the health office having to use his rescue inhaler. In our study, we found that fewer asthma symptoms were reported by our families, fewer ER visits for all causes. 20% of the 5th grade students with asthma passed the fitnessgram in our demonstration schools, which is really that abysmal number that only 20% did, and yet only 11.4% did at our non-demonstration schools. And we had a huge increase in health education. We found that we had increased collaboration with our community. Many of you try to get into schools. It's really, really difficult to try to get into schools. You have to have a contract. Is it your contract? Is it our contract? It has to go to your board. It has to go to our board. You have to have TB tests. You have to have fingerprinting. And you have to have somebody at that school who is willing to take the time, effort, and believes in your cause enough to bring you into the school. And that's what our school nurses did. They brought community resources, they coordinated, they got community resources in the door. We had the free dental screenings, free glasses, and when H1N1 hit, because we had our 4 extra nurses, I was able to go to public health department and say, you know what? San Jose Unified nurses can administer H1N1 vaccines. And we gave over 16,000 doses of H1N1 vaccinations to our students. We also found that we had improved test scores. This is one of those things that Dr. Rodriguez looked at a little bit later on in the project. In 2007, both in our demonstration and non-demonstration schools, we found that students with asthma were less likely to be proficient or advanced on their test scores. We looked 3 years later, and at our demonstration schools, that gap remained. And it remained for the duration of the project. 3 years later at our demonstration schools, that gap was gone. And it remained gone for the rest of the project. Our teachers and administrators. Our teachers reported they were very satisfied with the work the school nurse did. Our teachers and administrators said that having a school nurse helped them to work more effectively. And this was a favorite quote from a teacher at Empire Gardens. The school nurse can professionally share best practices best strategies for supporting and accommodating a student's medical needs while maintaining an instructional focus. So, in a nutshell, what we did, we provided the firm foundation by having school nurses and linking them to our school health clinics. Our students then had access to health care. We provided health education for the family, for the students, and we brought in the community to do that. We had a staff that was satisfied with having the school nurses, felt supported, and they worked together as a team, and the end result was improved academic success and health for our students.
Training where we focus on care coordination, community collaboration, leadership in the school, but also for nurses to understand the very unique perspective and complexity of how a school system works. I think that was brought out very much by one of our speakers. In Japan, where I recently did some work and consulting with their transition now to IDEA, they're putting a school health personnel into every single school in Japan. So they've been proactive and forward-thinking about this need. And part of their basic baccalaureate nursing preparation does include a specialty track in school nurse practice. And perhaps we could look internationally for some solutions for those kinds of things. Great question. Thank you.
So another question, I think this really could go to anyone. And I don't want to steal thunder from the last session of the day, which is on big data, but one of the things that comes up over and over is, who are these kids? Can we identify them in schools? I mean, before you can do any linking of the staff or, teachers to providers in the community, you need to know who these kids are, who their providers are, and then in terms of tracking data on what are the outcomes for these kids, does anybody know of successful models where there really has been, other than Melinda, I mean, you're engaged with Dr. Rodriguez in a very intensive study, but in the real world practice, are there good models for identifying and tracking these kids and their outcomes?
I don't think I probably need that, really. This is a huge, huge issue, and partly it is, unfortunately, the academic platforms are similar to our electronic health records, which are not great at abstracting and pulling data. And so actually getting the data out of these academic platforms is extremely cumbersome. It's extremely painful, and in some cases you really can't get it out. It has to be on an individual. You pull an individual record, and then you actually have to go ahead and put it into SAS or SPS or whatever. But so it is case by case in terms of inputting the data. So if they're using Infinite Campus, which I'm guessing, in Colorado we use Infinite Campus, PowerSchool, and GoEdStar. And Infinite Campus is the largest, and you cannot pull out that data in terms of using it as a registrar or getting the reports. They're pulled out one student at a time. So really using these data to help us monitor and really document the services that the nurses are providing, the type of care, and the monitoring, and really showing their effectiveness as well as the burden, is very labor intensive, and schools aren't interested in covering it. So it has been really a challenge, and so we're actually going out and doing a demonstration project in Colorado that we have just a separate portal that people are actually entering in that we've set up so we can actually start capturing this, because we have tried to do it within the academic platforms and it is so messy. The other thing is that I work in Denver Public Schools and Aurora Public Schools, and they have over 80 codes for absenteeism. It's a lot of codes to look in terms of figuring out what absenteeism really means. The other thing is that schools are so busy, and as you know, there's no one in there. A lot of times it doesn't get inputted. So a lot of the school nurses they're not really feeling comfortable with an electronic platform. They haven't been raised it, so they work a lot off paper, and so the information doesn't really get into the platform.
I just have a comment on that. With regard to mental health, for kids who are highest risk, those red zone kids, the tier 1 kids, I would say that because in most jurisdictions you don't have a very well integrated system between what's available in school and what's available in the community. You're going to hear more about school-based health centers this afternoon. We've just taken the individual school, and in this district in particular, and other districts in the other 57 counties besides Santa Clara, the money that used to come through the counties are now coming to the LEAs around mental health support. So some districts have chosen to actually take that money and instead of farming it out and paying for services outside, to hire on-site therapists. And so we're not able to do universal screening because that's usually a capacity issue. In Santa Clara County, we do not have any inpatient locked psychiatric facilities. We do have a crisis stabilization unit, but we have to send these kids far away. We have a total of 11 facilities, secure facilities, between here and the border of Oregon. And so a lot of what happens with our community is if a child or teenager comes into an emergency room, there is a communication that has to happen, so there's a warm handoff between what happens in the emergency room, what happens to the community provider. But as you say, that's done one teen at a time. We have a children's hospital, we have a school mental health service. We're able to do it in our locale because we only have, 65,000 population here. We have 4,000 kids in public high school. That's doable. But if you have a larger district, if you have a large locale, if you have an LA Unified, it becomes completely unmanageable. And so I think what you said is, for now, we're doing it, one school at a time and trying to identify who would be the person who would be the go-to. We actually ask the parent for permission to liaise with the school.
I was going to comment, too, that there's two places you can get the data. So you can get schools to try to track the health data, or you can get the health system to try to do a better job of tracking the educational data. So at least in 2 states, they bridge this gap, Delaware being one of them. So the school nurses have access to the electronic health record and can have screens that input attendance and school nurse contacts into the EHR. So we have already a structure with a very sophisticated system. And I think maybe if we looked at it the other way around, we might be able, because the healthcare system knows who the kids with the special healthcare needs are. What they're not doing is asking what happens during the school day, who's taking care of the kids at school, what is their attendance. They're not putting that yet, social determinants of health hat, on that end. But that's where the good data collection system is. So I think we need to figure out how to collaborate to start getting at big data.
When I look at the clusters in our local community in Palo Alto, for instance, one anecdotally at least hears a lot about the role of parents and parental expectations and what that means. And I wonder if there's any research that any of you can share related to that.
QPR is a program that can be used and deployed in communities. It is a program we have used. It's a program we are using. All teenagers in Palo Alto schools, in high schools, get trained in QPR.
Do you want to just say
point.
what QPR?
QPR is it's like CPR. It's suicide first aid. It stands for Question, Persuade, Refer. It's a 2-hour training. It can actually be done online, and it can be done for free because Santa Clara County has purchased a bunch of codes. And it is pretty good for being able to train gatekeepers in a community. The biggest challenge from a research perspective is that you look at the national data around gatekeeper training for preventing teen suicide. The biggest limitation is not that there are not a bunch of trusted adults who are ready in their toolbox and to look for signs of a teen in distress. It's that teens are generally not going to those adults. They're going to one another. And that is why all of our teens are being trained in QPR as well. And that's been a major initiative since 2009-10. But by itself, QPR is not enough, because what you have to do is really catch the kids way more upstream. So there are a number of universal prevention programs. Sources of Strength is one of them. That is a peer leadership program that connects peers to trusted adults and has been changed to change social climate on campus, changing the norms, increasing the likelihood that a teen will get help for another teen in distress. And then there are a number of other programs you can do for screening. So I think QPR is one method, but even on campus, one of the challenges at Stanford is The RAs, the RFs, yes, very important to get them trained, but it's even more important to get the friends of the kids, the other freshmen, the other sophomores who can look for signs of distress and get those kids trained. And I think that is an area that Vaden and other groups are exploring. And then the second piece was about parental culture, and we're a upper SES community that's almost 40% Asian. A lot of those kids are immigrants. Our groups actually studied some of those kids and looked at acculturation stress. And it turns out that for the kids who died this year, those did not appear to be high acculturation stress families. The kids who were trying to catch upstream, we hear a lot from these kids. We hear a lot about kids who, both majority and minority culture kids who say, I can't talk about this stuff in my house. There is a culture of performance. There is an academic arms race. That is all part of the culture of who we are. But we're not the only community like that. Why are we losing the kids? It's really, you can't simply look at that and say that is the reason, because there are plenty of other high-achieving communities who don't lose kids. As someone mentioned earlier, if you have a suicide in your community, or if you have a contagion in your community, copycats are most likely to happen in the teenage years and the young adult years. And then we have this very accessible Caltrain that comes through the town, which is where the vast majority of people take their life. So it's really like the Golden Gate Bridge. So one of the most important pieces of intervention now, science-based pieces, is means restriction. And that's really where a lot of the effort is going now. In addition to all the education about trying to decrease stress in the home and trying to achieve a set of balance and helping parents with what they've asked for, which is American parenting skills so that they can help their kids, because let's face it, there's not a roadmap for how to raise any kind of teenager, but particularly if you're trying to raise a bicultural teen, but also looking at what is the science behind restricting access to the most common method of death, which is at the Caltrain. And that's where a lot of the focus is now. Not only upstream around prevention and getting help earlier and looking for signs of distress, but also downstream and really restricting the access to being able to get to the train, which is how most of the kids and young adults are taking their lives.
Thank you very much.